9. Our concept again is clinical judgment. The chapters we're going to cover are chapter 33, 34, and 35. Please note the titles of the chapter: care of the child with a hematological condition, care of the child with cancer, and then of course the death and dying. This is how we will end our quarter. Module 10 is on advocacy and Module 11 is on health education. So we're pretty much ending the systems review at this point. The words I have in front of you all go through the 3 chapters that we're presenting with this module. We can go from something as benign as iron deficiency anemia to something as dramatic or devastating as leukemia, some of the other cancers, and then of course we have to talk about moving from curative care to palliative care, offering hospice, discussing organ donation, and of course then what the nursing care of the child who's going through death, or going through dying, I should say, going through dying, ultimately to die, and how we support them and their families. I said again, not a very pleasant way to end the quarter, hence, but these 3 chapters do fit very well together. So let us begin. We're going to start out with blood, of course, the hematological system, and when you look at the differential in each of the plasma, you'll see that on page 1074 of your textbook there are different values, lab values, based on age. We've said in the past that infancy is the most rapid growth period, and then things tend to slow down. Well, you see that that's a little bit different when we're looking at lab values. The requirements increase somewhat until people get into the adolescent age, and then things tend to taper out as a more of adult levels. Now, I'm not asking you to memorize this, but it is interesting and of note for you to at least read through it and recognize the differences. If you're working in a pediatric unit, you would become much more familiar with the lab values, to the point of almost memorizing them, because you would be using them so frequently. That is not the requirement now, but it may be in your best interest to at least look at it, recognize that there are differences, and note some of the differences that would be of the most importance, such as red blood cells, white blood cells, possibly platelets. Okay, anemia in itself is not necessarily a disease, but it is a symptom of multiple different diseases, and so that is why they use it as a large category. Why is anemia of concern? Because it is the oxygen carrying capacity, and it decreases if we know that a patient is anemic. The symptoms are oftentimes either asymptomatic or they're very vague, and it's very difficult to identify that this is what the problem actually is, because children can present with lots of different complaints. Some of the generalized signs, as I put here on your slide, are fatigue, headaches, shortness of breath, dizziness, and then irritability. As it gets more severe, there can be delayed motor function, tachycardia, systolic murmurs even may be heard or identified with someone with an anemic situation, because the body's trying to compensate for the decrease in oxygen. So anemia is a broad category, and then we look at some of the specifics. So iron deficient anemia, it is probably the most common problem that we run across, and we see it often in toddlers because they have an increase in calcium in ingestion. As children get older and tend to move further away from the milk products, we may see a replenishment of the iron. We would certainly encourage mothers to be giving vitamins every day, or perhaps even an iron supplement if necessary. Now, adolescents, we've already determined, might require a little more iron, because young women are starting to go through their menstrual cycle and losing some iron capacity there, and men, as they're bulking up a little bit, might be using up some of their stores. We know that babies have the stores for 6 months, and after that time we have to offer supplements if mom is breastfeeding, because there's not a lot of iron in the breast milk. However, formula itself has iron embedded into it, or infused into it, so that when we're giving formula to babies, they do get that increase in iron to help prevent the anemia. Some of the signs and symptoms, again, are asymptomatic or very severe, depending on what the situation is, how severe the problem is, and what are the compensatory reactions or behaviors that these kiddos have. Their bodies learn to compensate for the problem. The way we diagnose it, of course, is through a lab draw. We would recognize then that the patient is anemic. We would be looking at the hematocrit and the hemoglobin specifically, and that is why I was very specific, even in the obstetrical portion, about asking for those specifically, not necessarily the entire CBC, unless you wanted to pinpoint specific areas. So when you're drawing a CBC, you're looking at for more of a diagnostic issue. H&H is more of a screening to let you know that there is a problem, and then the CBC itself would be much more diagnostic because it's really relatively specific down to the MCV, the MCH, the retic count, that will give you much more idea of what type of anemia you're dealing with. The causes, again, are in box 33.1. It talks about several different reasons that someone could be iron deficient. And what would you think some of your nursing diagnoses will be? And one nice thing about this textbook is it also lends itself to giving you some nursing diagnoses in many different places. Fatigue is one of the big issues, of course, for children with iron deficiency anemia. Is they're fatigued, activity intolerance. There might be risks of injury or risk of falls because they're not at the same activity level or energy level. So there's a risk for injury there. So we would want to recognize what our nursing diagnoses are, and of course what our interventions are is to support, provide safety, and then replace where we can. Supplemental education, if we do require that our patients get supplements, what type of education do we give them? Number one, that the patients are going to have black tarry stools. It may cause some constipation. It should be taken with a vitamin C supplement. It should not be taken with food because that will interfere with the absorption. Liquid preparations can stain the teeth, so we need to alert the parents about that. So encourage the children to either rinse or take in another source of fluids to kind of clear that. And again, this is a relatively benign situation unless it gets so significant. Sickle cell anemia, again, it's an autosomal recessive condition, so both parents have got to have the gene for the child to have the disease. Sickle cell trait does not carry any of the disease entities. They just carry the genetic component, but sickle cell anemia or sickle cell disease is indeed a full-blown problem. Signs and symptoms of a crisis most often is the pain. They have pallor, fatigue, again because it is an anemia, but there's pain associated because of the sickling of the cells, which causes occlusions of the venous system. Now, this occlusion can be so significant that it interferes with the blood flow through the major organs as well. So we can have organ damage or destruction at any of those sites. So we really want to eliminate or decrease the opportunity for these sickle cell crises. Unfortunately, oftentimes children are have chronic health issues and come to our hospitals chronically because of this recurring problem of the sickling problem. What is some of the predecessor to the sickling is infections, dehydration, trauma, so we want to help avoid those things. We have tissue hypoxia when this sickling occurs. Again, a lab draw will confirm the diagnoses. It would be in our best interest to confirm the diagnoses upon birth, so we can be preparing and keep the parents alert at all times for any signs and symptoms, but this isn't always the case. In pregnancy, however, now we are checking moms for the sickle cell trait, and if she does have the trait, we will ask Dad to also provide us with a blood sample so we can identify whether or not this child is at risk. If the child is at risk, we probably would do much closer studies, and now they have included this in part of some of that screening that we're doing at the right before babies are going home. Nursing diagnosis, again, would be pain, fluid there's not a lot of fluid, so we would want to increase their fluids by giving an IV therapy. We would want to treat any source of infection with antibiotics, and of course pain management and range of motion to keep the joints from having any further damage. Keeping the joints elevated, ice to the joints, keeping them moving. So some of the education, of course, we provide is to keep children hydrated, keep them from activities that would traumatize them or cause injury to a joint or injury to tissue that is exacerbate this problem. Keep them free of infection, so they should maintain all of their immunizations, stay on top of all of those, and good hand washing, of course. So their activity may be somewhat restricted so that they can prevent any further complications from the disease. Again, some of the nursing diagnoses would be found on page 1080. Knowledge deficit, pain, alteration in tissue perfusion, activity intolerance, risk for injury, altered family process, ineffective coping, fluid volume deficit, and risk of infection, or indeed a true infection is present. So again, sickle cell anemia is a chronic condition, and you will see these children in and out of your facilities frequently. I think then we move on to thalassemia, which again is a generalized name for different kinds of inherited genetic disorders. We have beta thalassemia and we have alpha. Beta comes in minor or major, which breaks it down even further, and even the intermedia. And then we have alpha. So the most prevalent, of course, is the thalassemia, beta thalassemia that we see. Children that are symptomatic have enlarged livers and spleens, possibly some bone changes, as there's a demand for more red blood cell presence in the body. The bone that normally doesn't produce the red blood cells will start to move into action, and it can cause some deformity, especially if that bone is undergoing some change or growth. So we need to be watching for that. The way we diagnose this is through lab, which is a hemoglobin electrophoresis, where they can actually break down all the cells and look at them to identify what this link is. Nursing diagnoses, again, would be pain, dehydration issues or fluid volume deficits. It is a genetic link, so once we identify it, of course, we could be watching for the problems. We may have to do blood transfusions, which can cause its problems in its own. If children undergo too many blood transfusions in a short period of time, due to the high levels of iron in the plasma, the red blood cells, they can have iron toxicity. So we have to be watching for that as well. And then, of course, there's bone marrow transplants that we can do to help eliminate the problem. Hemophilia, again, is X-linked deficiency of either clotting factor 8 or 9. This affects men usually because it is on the X part of the chromosome. What is happening is that the bleeding is prolonged. So our signs and symptoms, again, are diagnosed with periods of bleeding, especially into the joint area or into the soft tissue. So you'll see bruising, or they won't be able to stop bleeding. Now, this may not be identified immediately until perhaps at birth with a circumcision, or later on with a tooth extraction or some type of injury that has occurred and we cannot get the bleeding to stop. So a nosebleed or some cuts or scrapes when you fall. Now there's different, I don't want to say levels, but severity of this disease. So it can be minor or it can be pretty extensive. Nursing diagnoses, again, risk of injury, pain related to the bleeding episodes, knowledge deficit, and potential for impaired physical mobility because of what's happening to the joints and the muscles and the soft tissue. Education is safety, keeping children safe, so decreasing the activity that would cause any trauma to their joints or their tissue. So they're going to have to find activities that may not be as physical. You don't want to have some physical activity. You want to prevent any cutting. So with razors, we'd want to use electric razors. You'd want to alert if there's any type of invasive procedures that have to be done. We need to alert the healthcare staff of the possibility. Now, we can do blood transfusions or give them factor 8 if necessary. So those are some of your educations. Von Willebrand is also a very common inherited bleeding disorder. But you're going to find it both in male and females because of a missing, I'll call it enzyme. It's probably not an enzyme, but a factor. It is missing a factor. And we're not going to go into it extensively. If we went into every disease that is presented, we'd be here for a very long time. So ITP, idiopathic thrombocytopenia purpura, again, it's autoimmune. This one is. And it's the destruction of platelets, and it causes petechiae. You can see it in a chronic or an acute settings. So acute is much more self-limiting, meaning it usually can handle itself and take care of itself, and it's usually in much smaller children, and they tend to somewhat like outgrow it. Isn't right the proper term to use, but they do tend to outgrow it. The acute is often benign, and it occurs in much younger children, and it's usually after some type of viral infection that this becomes an issue, but then once the infection is resolved, of course, we revert back and do not have a problem. The chronic ITP is most common in adults. We usually identify this when the platelets get below 20,000. So we're going to do a bone marrow aspirate, what we used to call bone marrow biopsies. It's now called an aspirate, bone marrow aspirates. We might find in providing treatment, we want to be very careful of the very young because it can cause ICP if we're giving fluids back too quickly. And because of the bleeding that we see throughout the entire body, it can be erroneously labeled as child abuse. So we want to be cautious, and before we start making accusations, that we understand what all the signs, symptoms, and problems are. All right, moving further on. Aplastic anemia. You know, when I first was a brand new nurse, and even later on, I would think that this was only about the white blood cells. But it is not necessarily, that is not true. It is rare, but it can be extremely serious because it's all of the blood particles that are affected by this, where there's a decrease in everything, red blood cells, white blood cells, platelets, and everything. So it's a severity dependent on the results of the bone marrow. So when we do a bone marrow aspirate, we're going to identify how severe, how dangerous, how devastating, or how fatal this is for this individual. It can be rapid and fatal, or it can be a chronic problem that can be controlled. And again, we identify it by doing a bone marrow aspirate. Nursing diagnoses, we want to remove the causative factor. So if we look in box 33.2, we see lots of reasons why we have acquired aplastic anemia. Radiation, autoimmune, some pregnancies, some of the viral infections, some of the toxins in the world, chemotherapy, some of the drugs that are used over long periods of time can lead you to this disease. The resultant treatment is stem cell transplants usually. We provide supportive care and, of course, immunosuppressive therapy with either steroids. Now, when a child becomes immunosuppressive, we have to ensure that they're not going to be exposed to any form of infection. We would want to maintain their immunizations except when it becomes a live virus, and those of course we would want to avoid. What happens also is that there's no neutrophils, so this patient cannot respond to any types of infection. And that is the problem. So children might die from the opportunistic infection as well as from the disease itself. So education is all about support. It's all about providing a clean environment or a relatively sterile environment, keeping them away from other children that might be ill. Blood transfusions. I really felt it was necessary to spend some time with this. Now, everything we've already talked about, you need to go back through and read, of course, and be comfortable with. You're probably not going to be tested on anything extremely specific because these are things you've already heard about, read about, and will be reading about in Nursing 3, if you haven't already been exposed. Blood transfusions do require consent. They require a type and cross match. And you need to know the difference between a type and screen and a type and cross match. If someone comes in for a invasive procedure that will not probably end up in any surgical intervention, we probably will do a type and screen. If we know we're going to have to give blood, we're going to do a type and cross match. The cross matches are only good for 72 hours. So if someone comes in and we're sitting on them, kind of watching them, we've done a type and cross, but we keep them in an observational mode. We're kind of watching, making a decision whether surgery needs to be done. If we have expired that 72 hours, we need to draw it again and resend it to the lab for the cross match. Before we give blood, we have to have assessment vital signs done. So a pre-transfusion, we need to have some vitals done. When we do that, then we call down for the blood when we're ready to infuse it. We can't have it on the unit for more than 30 minutes. The max infusion time, you know, is 4 hours. You want to ensure that all the patient information is correct and that the lab is aware of all the information. It has to be checked at the bedside by 2 appropriate healthcare personnel, and a lot of hospital policy is that it has to be 2 RNs. Now, you'll have to check your hospital or your facility policy if you know that you'll be administering blood. Some places there's just not that many RNs on a unit at any given time, and so that's not always feasible, so they may have altered policies based on what the need is. Again, once you've started the blood, you'll do a baseline vital signs. You're going to start the blood very slowly. You're going to be checking vitals and checking on them every 15 minutes. You'll run the blood with normal saline, but no other medications or solutions. Do not add medications to blood. Do your vital signs per your patient policy, or your hospital policy, I'm sorry. You have to keep the blood products ID information with the bag. Keep the bag. Has to be kept for, I think it is an hour or so after transfusion to ensure that if there's any adverse reactions, you will be able to note the lot number, the dates, and where it came from. You have to monitor for some adverse reactions. And I would like you to be able to tell me what those adverse reactions might be to a blood transfusion. Other policy requirements, you'll have to know what those are for your specific facility. Every facility has a blood transfusion policy. You'll need to note that, read it, and somewhat, not memorize it, but be very comfortable with it. In fact, if you don't run blood for a long period of time, it's always good to pull the policy out once again when you receive an order to start blood, unless it's in an emergent situation. Cancer, now we're moving on into the next chapter. We're talking about cancer. So before we do that, let's go back. If we look at hematological disorders, we know that oftentimes things are asymptomatic. Even severe issues such as aplastic anemia is going to be asymptomatic initially, or it's going to have some very vague symptoms. So just because a child comes in with a cough or a virus, has flu-like symptoms, we should not rule out that there's this issue as well. That's why it's always a safe idea to draw a CBC, because that is diagnostic. Now, that's not to say that I'm going to be able to tell you that this patient has hemophilia, or this patient has von Willebrand's, or this patient has, well, sickle cell we should be able to see, but some of the other much more obscure diagnoses until we do an electrophoresis, and that would be done by a hematologist, someone who is specializing in care of diseases of blood system, and there are many more out there than what we're hitting. You need to recognize that you need to do initial screening exams on your patients. Do your due diligence and do an assessment. Identify, look for any bruising, look for any petechiae, look for signs of fatigue, lethargy. Talk to the parents. Find out what the normal behavior is. Look at the mucous membranes. Look at the conjunctiva. It'll also tell you if this patient is anemic. Talk to them about what their behavior is, what I've said. Do they have anorexia? Are they complaining of headaches? What's their urine output been like? Because anemia will also affect the renal system and decrease the amount of output. So be asking those questions when you do the CBC. You'll have a general idea of in which direction you're going, but we will not be specific until biopsies are done if you're looking for something much more definitive. Again, nursing diagnoses are fatigue. You're looking for injury possibilities. You're looking at activity intolerance. You're looking at dehydration. And so it's always a good idea to be talking about the hydration status. What does this child eat or drink? And try to identify that. So if a child is very lethargic, you know they're not going to eat or drink much, which is going to exacerbate the problem. So really do a holistic view each and every time you meet a patient, because you do not know what system you're affecting. We've talked about multiple systems up to this point, and you do not want to negate the fact that each of them interact with the other. And that's part of your critical thinking when you're doing your assessments. So now we're going to move into cancer, which cancer, when you hear the word, sounds like a death sentence oftentimes, and we know that that's not the case anymore. Great strides have been done in the medical research area and finding not cures for cancer, but a greater rate of remission so that people can continue to lead relatively productive lives with maybe perhaps a little more aggressive or frequent monitoring to identify if anything is returning. Cancer for children is a little bit different because it can begin in the embryonic state. It isn't because of another condition acquired necessarily. This is something that they may have already had, and now it has become the problem as they have gotten older, where adult cancers are more because I didn't take care of myself, because I didn't eat well, because I'm smoking, because I'm not taking my medications. I've exposed myself to different toxins. I've worked in an area where toxins have been part of my life. I've been a sunbather. I've been an outdoor sportsman, and so I haven't been taking care of things. So oftentimes cancers in adults are relative to lifestyle choices, where with children that is not the case. The cure rate is better for children because we can be more aggressive. The cancers are sometimes more faster growing, and so we identify them quicker, and children do respond quicker to treatment. Now, that's not to say children do not die from cancer. It's just to say that we've been able to find faster means in which to put them into remission. Leukemia is probably one of the most common. It is the most common cancer that you're going to hear about, and it's a generalized term, just like anemia is a generalized term for blood problems, but leukemia is a generalized definition. It's blood-forming cells, and that's where cancer will attack these cells. It's acute. The acute form is more aggressive and attacks the immature cells that cannot respond, where chronic leukemia is less aggressive because it's attacking the mature cells that now can respond, and they're doing the job they're supposed to do. If it attacks the immature cells, those cells get destroyed before they even are allowed to do the job that they were made to do. So leukemia is the generalized term. There's different types of leukemia. There's acute lymphocytic leukemia. It is the most common. The signs and symptoms are going to be based on how much infiltration of the bone marrow has taken place. You might see fatigue, anemia, anorexia, joint pain, headaches, petechiae, much of what we have seen in some of the blood dyscrasias as well. Nursing diagnoses and interventions. First of all, we're going to do a bone marrow aspirate again. We're looking for 3 things that we can do to intervene. We can put them into remission. Then we do a consolidation and then a maintenance program. Oftentimes when we're talking cancers, especially in children, well, adults too, we talk about the complementary care or homeopathic care, other types of direction we might want to take when we're looking for cures. Most people with cancer are looking for anything that they think is going to help. Scientific research has shown that a lot of the complementary therapies may be more psychosomatic, but indeed they have been found to be beneficial. Some of it is all about changing your attitude, redirecting, thinking positive thoughts, better nutrition, getting better exercise, avoiding some of the toxins so they get rid of anything that may be non-organic perhaps in their diet. So these things can be offered and should be integrated into a care plan. They're not the be-all end-all, but physicians have been aware of these and are embracing using this type of therapy in addition to the usual therapy that is used, the chemotherapy and the radiation. It isn't the only thing that we want to use, because we have to attack cancer in a very holistic way so that we can involve the entire body, the entire mind, and the attitudes. So medications, vitamin supplements, alternative therapies are also welcome, such as acupressure, acupuncture, water therapy, yoga, other things. So a lot of things are provided when we're talking about the care of a patient with cancer. So ALL is one form of cancer, then AML is the acute myelogenous leukemia. I probably am not pronouncing that correctly, but that is the second most common. Again, the symptoms are very vague. They have flu-like symptoms. It's identified with the bone marrow aspirate again, and once it's identified, treatment begins, and we usually start with chemotherapy. So those are your leukemias. Brain tumors. There are the solid tumors, and we're going to start with the brain because that's the beginning of the body. These originate in the brain, again, in children. It's not like adults who have these grow later on. These have been there, but because of the rapid growth, we usually can find them pretty quickly. The way we identify them is seeing the changes in the neurological signs, so level of consciousness, gait, ability, motor function. That's why it's very important that you know the milestones of children. Once we've identified a brain tumor, then the job is to resect it, biopsy it, and then continue treatment. We have to give medication to prevent edema from the traumatizing result of surgery. So usually it's Decadron is used, and I would ask that you kind of know that drug. You're going to do frequent neurological assessments, prevent infection. Of course, pain management is always the case when we're dealing with any type of cancers or surgical intervention. Then we might go for radiation. And you want to be very cautious about this because there is a growing brain depending on the age of the child and the developmental level. However, we know now that we can pinpoint it and use much lower amounts of radiation because we can pinpoint the lesion instead of giving an overall general radiation to the brain. In addition to that, remember, we're not just dealing with patients here, we're dealing with families, we're dealing with siblings, and with extended families, and we always have to keep them informed, provide support both to the family and to the patient. That is crucial, especially at this time, because again, the word cancer is devastating, it's frightening, and you never know quite what the outcome will be. And so it's a constant vigilance, and we want to keep the families as involved as possible. When we talk about family-centered care, this, out of anywhere else, would be where we would want the support and the participation of families. We want them to be with their children. There is no visiting hours. There is no restriction. Of course, we want to educate and explain to them if these children are put into a neutropenic situation that contact isolation or hand washing, perhaps even changing their clothes, is going to be crucial to help keep them safe. Bone cancers, again, we've moved from the solid tumor cancers, and there's multiple solid tumor cancers. Please do not ignore what's in your textbook. I'm just kind of I'm highlighting, obviously, and I'm not going into any depth, and then you're going to go back through and do some reading and highlighting. The key is that we want to see the similarities. We want to see what things interact. We want to see where nursing diagnoses and nursing interventions are not different. If I say the word cancer, you should know what the nursing interventions are, regardless of what kind of cancer it is. There are some basic things we always do. When we talk anemia, there are some nursing interventions that are common to all anemias, regardless, but then there are some other nursing interventions that have to take place based on the specific diagnoses. So when we're teaching and talking concept, this is what you should be thinking through. So osteocarcinoma, that is a bone cancer. This can happen because of an injury or a long-term infection that has now migrated into the bone. We know that the bone marrow is, of course, grows very rapidly and develops rapidly and reproduces rapidly because it is where the blood products originate. Therefore, there's a lot of things changing and growing and happening. So it's a great place for cancers to embed and then spread. So metastasis is pretty significant. Signs and symptoms, of course, with an osteosarcoma would be pain and edema. However, oftentimes these get ignored as a sports injury or just a bump and a bruise, and people kind of ignore it, walk it off, rub it down, put some ice on it, we'll use the rice technique and you will be better. Well, indeed, it doesn't get better, and you may see that children start to walk with a limp when they're not being watched. Some kids will do that to kind of play a game, but you'll notice that this continues to happen. So a bone scan will be done. This is how we identify an osteosarcoma. I'm getting all my words confused. They usually begin with chemotherapy first to decrease the size of the tumor and then surgically excise it. Now, depending on how severe it is, the tumor perhaps might be removed. partial bone might be removed, or they may have to be a total amputation. Depending on the age, the developmental level of the child, this can be very devastating. It's always going to be traumatic, but again, the younger the child is, if this happens and is discovered, the easier it is going to be for them to cope and adapt with the change. When we're talking adolescence, it's going to be much more severe, and we have to really be looking out for depression, withdrawal, social isolation, all of those nursing diagnoses as well. Ewing sarcoma is another. It's highly malignant, and we see it more often in males, according to your textbook. Again, the signs and symptoms are pain and edema, and there's a delay in treatment once again because we contributed to sports injuries, and people don't look at it. It differs from osteosarcoma in the histological review, which we don't need to get into, and it usually attacks the long bone. So again, you're looking more at chemotherapy, surgical resection, and possibly amputation. So let's talk about nursing care in general. There's some areas that we want to look at. Nutrition is one. Chemotherapy, infection, radiation, some of the medications you'll need to know that, surgery, pain control, and psychosocial issues. Those are just to highlight the main. You know that chemotherapy, radiation cause some challenges for anorexia, nausea, vomiting, and we need to be able to counter that. The most common drug we see that's used is Zofran. Then we want to offer oral hygiene, of course. We want to offer snacks. We want to offer fluids, what is tolerable, that will not be caustic to the mucous membrane, because you are going to have some erosion of the mucous membrane, both from vomiting and possibly from the chemotherapy. Because their nutritional intake is going to be poor, possibly, they're going to have some weight loss. We may have some malnutrition. When a child becomes malnourished, that is going to impede their growth. We impede their growth, we're going to have some developmental delay. So you're looking at all of these events that can cascade and become more of an issue. So it's imperative that we focus on nutrition and find ways always to help improve the nutritional intake of these children. So we're watching I&O as well, because we don't want them to get dehydrated either. They also become much more susceptible to infection when you're malnourished, you're not taking in a good nutritional intake, especially vitamins, minerals. So infection, of course, is going to be a huge problem for chemotherapy or radiation. They become a little more neutropenic. They don't have the ability to fight infection. So we're going to have to be very cautious and very mindful of infection control issues, be it gowning, gloving, hand washing, masks. Maybe they need to wear a mask when they're out and about so that they're not taking in, making sure their skin is completely intact so there's not an area in which they're going to have risk of infection. So if they have an abrasion, we need to be sure that we're cleaning it well and keeping it covered. Chemotherapy on page 1124 and 11 through 1126, they go through some of the effects of chemotherapy. Most of you probably are very clear and aware of those, having studied this in Nursing 2, or going to have studied it in Nursing 2, so I'm not going to spend a lot of time talking about it so that you don't have to listen to it over again. Chemotherapy, of course, is usually IV therapy that we give. Children come into centers. It's put into ports. They have their PICC lines or their ports that are placed in a part of their body that is kept covered for easy access so that we're not continually having to start a new IV line. Mucositis, anemia, diarrhea, constipation, all of those issues can be relative. Alopecia, of course, is the one we always talk about, losing your hair, are some of the risks. Pain control. Radiation, again, I've already mentioned that radiation is done with caution because of the risk of destroying tissues or organs that we did not want to. However, we know that we can pinpoint it much closer now and provide much more definitive care. Radiation is used with some hesitancy in children younger than 3 years of age because it can cause severe damage to healthy cells, restrict growth, and of course the fertility is an issue. So they're very cautious about using radiation. Some of the medications, like I said already, you'll need to be aware of those, and those are clearly listed on page 1120, 1121. Again, I am not suggesting that you memorize them, but be comfortable with some of the names of drugs, so if you do see them again, you can at least know what classification they're in and what their possible use was. I'm not asking you for dosages or anything like that, so just have an idea. Surgical intervention, when we start talking surgical intervention, do not forget we're talking preoperative, intraoperative, and postoperative care. What is the nurse's role? What type of interventions do you provide? We're always looking, we go through Maslow's hierarchy of needs. Then we talk about pain management, we talk about vital signs, we talk about hydration, mobility, skin, we talk about renal systems, you talk about respiratory, we already said respiratory, cardiac issues, circulatory issues, so you're looking at all those things. So be aware of what your responsibility is if you are taking care of a postoperative patient, be it cancer or not cancer. Postoperative care for the pediatric patient does differ somewhat from the adult because children tend not to talk with you and they will withdraw and not be as open and share what is necessary. And we cannot negate the need to look at and do a complete assessment on them just because they tend to be a little hesitant or shy or argumentative with you. We still need to accomplish that full assessment to ensure their safety and their well-being. Pain control, again, do not forget about non-pharmacological methods, not to say that we're not going to treat their pain with medications, but also look at the non-pharmacological measures which will enhance the use of your pain meds. And morphine is used more often than any other drug for children. And we can use PCA. Usually for children over the age of 5, they can use a PCA so they can control their own pain management. We know that children with chronic illness versus children with acute illness may have different pain management requirements. Cognitively impaired children may not be able to express it as easily. We want to ensure that we're using the right tool so that we can communicate very clearly about what their pain level is. Psychosocial issues, again, we are not alone in this. We may not have all the answers. We may not know even what to say to a family who's just given a new diagnosis after a surgical intervention that this is a non-operative tumor, that this will take some chemotherapy for quality of life, but this is a terminal illness. Your child will die. What do we say to that? How do we respond to that? How do we handle our families? And we are not equipped to do that, and that's okay. You're not going to be equipped to do everything. This is when we call in our resources. We call in the child life specialists. We call in the grief support people. We call in our supervisors, other nurses, the spiritual counselors, whatever the family requires. We don't have to do it alone. So please do not expect that you are alone in this. Please use your resources. Chronic issues, this is not necessarily cancer, but some cognitive issues or chronic health issues. Some children, because of the advances of medical science, were born very prematurely and have developed some issues that have now become a chronic health concern and need frequent monitoring. So we're seeing a lot more. Children are living longer, are living healthier, more productive because of early recognition, and we're finding means in which to correct or manage the disabilities. So do not be surprised when you have more acutely ill, or I should say even more chronically ill children or adults, now because they're living into adulthood, that they've had these conditions all their lives, where in the past these children would have not survived their illness or their condition. Some of them are technologically dependent. We use a lot more ventilators, mobility devices. We're talking either acquired or congenital issues. Children with muscular dystrophy now are in mobile devices, and so we're going to have to learn how to use those as well. This also has an impact on the family. Their whole life gets turned upside down or changes based on the needs of this child and their equipment and their schedules and all their therapy. So we have physical therapy at this hour, we have speech therapy at this hour, we have school, we have activity, we have to check on vital signs, we have to check on I&O, we have to check on nutritional, we're going to make sure we feed them. So there's a lot of care that is provided, and some of you may even have family members who are dependent on very strict, structured schedules that impacts the entire family, impacts the siblings, impacts their activities as well. And so we as nurses have to respect that, understand it, and realize it's not just the patient that's being affected by these issues, but the entire family, possibly the extended family, and even the community at large is being affected by these health care needs. So it is not just an individual issue, it has become a global issue. And then as we're moving further into chapter 35, we're going to start talking about the dying child, or the child that has impending death. The responses we make to the child and to the family is going to be dependent on their knowledge of death, their understanding. So depending on the developmental age or chronological age of your child, they may not understand the concept of death. They might have seen a pet die and realize they're no longer here, or think that they're just chronically sleeping. They don't understand that it is an end to life, and so sometimes that's very difficult. Dr. Kubler-Ross, who is a well-renowned theorist on the death and dying, did start with children. That's where she started her study and her research, because children were much more open to discussion and could describe things a little bit clearer to her, and through art and pictures, she learned to communicate with them and learned a lot more about the issue of death and dying. And she found that children and families, and then it translated into adults, go through a grieving process, be it they with the diagnosis or a family member. They all go through these different stages. Now, they each go through the stages at different times, at different rates, and some may never get through the entire 5-step stage. But these stages are there, and you can see the significant behaviors that accompany them. We have bereavement teams in hospitals. So when a child or a family member is given a diagnosis, we can call again on our resources to bring the bereavement team or the grieving team in to help with the communication, help with the arrangements, help with decision making. That is not to say we're making decisions for the families or the patients, but we're allowing them or giving them the facts so that they know what decisions need to be made. Do we shift from curative care to palliative care, and when do we do that? When is it time to realize that this is no longer a possibility? How many more procedures are we going to put our family member through, or do we put them into palliative care to keep them comfortable and provide them with quality of life? Personal touch, they've identified, is extremely important to patients who have this disease, because they don't want to feel like they're contagious. They're not contagious. They're just as afraid as the people caring for them or as their family members, and so we need to touch them. We need to offer support. We need not to be afraid to treat them with the dignity and quality of life that they are owed. Sorry, I'm stuttering a little here. Allow choices. Perhaps they'd rather be home. They'd rather be in hospice. Maybe they'd rather be in the hospital. Maybe the family prefers that they're in the hospital because they feel like they'll get better care. Maybe they don't understand all of the aspects of hospice care or where they can go for hospice care. Do they understand that there are lots of choices about food, about drink, about what type of care we provide? When we talk about advanced directives, it can be anywhere from I want absolutely nothing to I want food and water and pain control, or I do want a ventilator, or I do want. So they have to help, you have to help them, and they have to help learn what decisions they are allowed to make. Of course, they're going to be initially anger or shock, and then anger. And then you may be the brunt of that anger, and so you're going to have to be very strong and never take it personal. It's just them acting out in their own fear and their own grief. Pain relief, of course, usually becomes the focus when we start talking palliative care, hospice care, or a child that is dying, especially in a cancer situation, where we know it can be very painful and devastating as the body systems start to shut down. We want to offer them a relief from dyspnea, give them the oxygen, give them some type of ventilation, provide them the opportunity to communicate and be a part of the family as long as possible. There's nothing, I think it's more frightening or more disconcerting to families when someone is completely narcotized or sedated so heavily that they cannot participate. It's very important oftentimes for families to say goodbye, and so to do that you have to have a patient that is relatively alert. Fear of family withdrawal can be addressed, sometimes out of fear of not wanting to see the child die. They ignore the idea and they stay away. Or they're not going to touch you because they don't want to hurt you, or they're not going to get close, or they're not going to, don't do this because it's going to make it happen faster. If you go play, you could die while you're playing, or I'm not going to let you go to sleep because you could die while you're sleeping. So we really have to address those fears with the family. When we're talking about the dying child, there's the fear of pain, there's the fear of dying alone, and then the family's fear that the child will die alone. So there's a constant vigilance. But we have to be realistic about those things as well and reassure the families, if we are the nurse that's caring for this child, that we will alert them immediately if there's changes and that they need to take care of themselves too, or they're going to get sick. And if they get sick, then they're of course of no support to their family member who's dying. Siblings need to participate. They need to be a part of this as much as they choose to be. We can't force someone to come in and sit with a dying child, but they need to be aware that this is their brother or sister, and they need some time to share and spend. Maybe a favorite game or a favorite movie that they can watch together. Some way to communicate. But do not forget to include the siblings in this whole process. Each treatment is evaluated for effectiveness, meaning that how many painful procedures do we want to continue? How many bone marrow aspirates do we need to do to find out the same information we already knew? How many bronchoscopies do we need to do? How many ports do we need to place? How many IVs are we going to put in? So we really need to think about what we're doing, why we're doing it. Oftentimes this is where an ethics committee comes in and helps the family as well recognize what the treatment plan could be, what it is, and allow them to make the decision, but put it all out there so that they understand what it is they're asking. We know that the dying person makes different sounds, different requests, different behaviors, and we need to alert the families to that too, because that's very disconcerting. Even to healthcare workers, if it's your family member, it can be very disconcerting. And so keeping watch on the family as well as the patient to help them through this process as well. And of course, hospice care, again, becomes very family-centered. There are no restrictions. There's no can't be done. And again, when we're talking about grief, I again bring up Dr. Elizabeth Kubler-Ross, and these are her theories where the family members or the patient go through the 5 stages, and the first stage is denial, the second stage is anger, the third being bargaining, then depression, and then acceptance. Do we get to acceptance? You may not. Or maybe today you're accepting, but tomorrow you're going to be angry again. So this doesn't mean that you get through a stage and then you never go back. That's not necessarily true. You're going to waffle back and forth and wave back and forth through all these different stages of grief. One of the things that came up in your textbook was allowing families or parents to assist in postmortem care. I think that'd be a little unnerving to some nurses. But again, if we are comfortable with death and dying, and we are comfortable with taking care of the patient who has died, and we are comfortable with our own abilities, I think we'll be okay allowing the families to participate. Because, yeah, they're probably watching you a little bit, but more they're focused on the family, and they want to ensure that they have the last say or the last moments that they possibly can. Then, of course, we have to bring up the subject of tissue or organ donation. And again, this may not be our role. Every facility has a different policy on this. Oftentimes, if we know someone is close to dying, we can prepare the family by telling them that we would like to contact the organ donation organizations. And then they come in and do the talking and provide the risk-benefit whole discussion with the families and get signatures taken. Now, children do not have the ability to sign for donor cards necessarily, but they may have verbalized their interest if they're old enough. And other than that, the families have to make this decision. It'll be a very difficult decision to make, whether or not they want to donate a part of the organs or skin or hair or whatever. Then, of course, the very final step would be arranging funerals, which is something parents don't want to be talking about doing for their children. We as nurses, especially in a hospice organization, are going to be very aware of what funeral organizations or funeral parlors, funeral directors provide services at either discounted or pro bono, or what is a package supposedly. So we may want to direct families to those organizations. We also want to find the organizations that are very sensitive to this need for this family. Again, everybody's very different. You don't plan to bury a child, and so there's probably very little that has been done in preparation for this. So we start from scratch, and families need to have some direction on that. And unfortunately, nurses don't have a lot of direction on that either, and that is something I've asked Ms. Gauthier, Ms. Porter, and the dean that perhaps we need to include in part of our curriculum, is talking a little bit more about that, so we're aware even of some of the options. Not that we'll know everything, but it gives us, because every area of the hospital that we work, we're going to face a patient that's going to die or has died, and we need to be a little bit prepared in how to deal with the family and answer some of their questions. And that concludes it. So again, this isn't a be-all, end-all lecture on every point you need to know. You definitely have to read your textbook, or at least peruse the textbook, and we'll have study halls. But the goal for you always has been to look at the concepts. What are the nursing interventions based on the concept? If I'm talking perfusion, which was one of our big concepts under reproduction, if I'm talking advocacy, which we haven't gotten to yet, but if I'm talking about advocacy, what are the nursing interventions that I would provide, regardless of what the specific issue is? Look at the concept, know your nursing interventions, and then look at the specific diagnoses and redesign or add to your list of nursing interventions. But this way you will always know the direction you're supposed to take, and you should always be able to put those critical thinking eyes on and look a little beyond. Always look at your patient holistically. Look for things outside of what you automatically think it's going to be. Because a patient comes in with a fever, we automatically think they have an infection and we're going to give antibiotics. Not always the case, right? So really think it through. Thank you very much, and as always, if you have any questions, you should feel free to email me. And again, we'll be covering some of this information in a study hall. Thank you very much for your attention.